So what your patient should know before you take him to the OR to perform a bulbar urethroplasty. Of course, he has to know or he has to get a little information about the procedure you'd like to use. And there are a couple of different procedures you could use. There are the one-staged transecting techniques. The classical technique is the end-to-end anastomosis. Jay already discussed it with you. However, today are still indications to do this procedure. In those cases with a post-traumatic stricture with a complete obliteration of the urethra and a severe spongiofibrosis, there is no way then just to take the scar out and do an end-to-end anastomosis. If it's a longer segment, you can do an augmented anastomotic repair with a graft, as this was published by Guralnik and Webster. So you make on one side an end-to-end anastomosis, and then you augment it with a graft. On the other hand, we have the more modern technique, the non-transecting technique. And the simplest one is this one, initially published by Jerry Jordan and later popularized by Enrich and Mundy. It's a Mikulicz procedure. That means you make a longitudinal incision and then a transverse closure. But this, however, only works in very short strictures. And then we come to the simple graft augmentation techniques, which are usually used today. That means you open the urethra and then you put a graft on either on the ventral, dorsal, or lateral side. And then if we have a nearly complete obliteration of the urethra, the ANTA and also the MANTA technique have been described. That means you open your urethra, you resect the stricture at a mucosa level, you do a mucus anastomosis, and then augment it with a graft. And either you can do the augmentation on the dorsal side, which is the ANTA technique, and we published the MANTA. That means we do the mucus anastomosis on the dorsal side because the way of the urethra is shorter, and put the buccal mucosa graft to the ventral side. And of course, you have two-staged or even multiple-stage procedures. So the patient has to know that you might change your planned procedure according to the intraoperative findings. So when we look to the literature, we have quite a lot of data on description of procedures. We have not so many data on surgery-related complications according to intraoperative, early postoperative complications, and also functional outcome with respect to intermediate and long-term follow-up. However, we have good data on success and recurrence rate. And in the following, I'd like to focus a little bit on the surgery-related complications. One of the intraoperative complications that might occur is bleeding. However, in bulbar urethroplasty, it's rare, and blood transfusions are really rarely needed. If it happens more in the posterior post-traumatic stricture repair where you do a bulboprostatic reanastomosis. Then we have catheter-related complications and usually suprapubic catheter-related complication. Also, this is very rare, but if you have a patient with multiple intra-abdominal surgeries, these are at risk if you put a suprapubic catheter in during surgery. And then we have complications related to the lithotomy position. This might be deep venous thrombosis, followed by a pulmonary embolism, and compartment syndromes. There are only case reports, and these cases usually are related to long operative time. In my institution, a simple bulbar urethroplasty takes about an hour. I have seen referrals from other institutions where it took them 7 hours and the patient developed this complication. So if you need more time for this surgery, then please take care of a good positioning of the legs of the patient. Let's switching to the early complication, and the overall incidence is low. This is a publication on at least 1,135 patients with urethroplasty, and these were the 30-day complication rate. And as you see, main complication was urinary tract infection, followed by perioperative transfusion and a superficial surgical site infection. And then you had a couple of less frequent infection like reoperation, deep surgical infection, deep venous thrombosis, and pulmonary embolism. And the authors stated that they have a higher risk in patients with diabetes, with pre-op blood transfusions, pre-op sepsis, lower hematocrit and albumin, and longer operative time. So longer operative time is really something that has an influence on your complication rate. Let's move to wound complication, and this is a nice publication from the group of Keith Rook. They compared a longitudinal incision with a lambda incision, and it was a retrospective analysis of 829 bulbar urethroplasties. Here, they considered the 90-day postoperative wound complication rate, and they observed a wound edge separation in 7.4%, incision pain or scrotal neuropraxia or scrotal pain in 6.1%, UTI or epididymitis in 3.5%, and then a few other less common complications. And interestingly, the complication rate was with the lambda incision with 24.9% higher than with the median incision, 12.0%. However, the major complications were Clavien-Dindo classification 2 or less. Let's move a little bit to pain and the sensory neuropathy, because this is really bothering the patient. So in another study, this was seen in about 6.1%. However, there are also publications that show a higher incidence up to 14%. The good news is in 70%, the patient had a complete resolution at a mean of 271 days. So if you have a patient who is complaining of that, you can tell him it will resolve by time. Let's switch to the harvesting side when we use buccal mucosa. You can use the lip, cheek, and the tongue. The lip is mainly used in children. The cheek, typically used in adults, and a typical complication is swelling, numbness, and difficulties of mouth opening. There are some people that use also the tongue. I never use it. If you use the tongue, a complication might be tongue protrusion and difficulties to speak. Let's switch a little bit more to the harvesting side and whether it makes a sense or a difference to close or not. And we did a prospective randomized study to compare these two groups. What we could see is they had a tender sensority pain at any time of our investigation, but the oral pain decreased over time, whether we closed or not, and you can see here the two figures. So what we could say is that at 6 months, no impairment of mouth opening was achieved in up to 66%. We had, however, a moderate alteration of taste perception in up to about 10%, a moderate alteration of salivation in between 5 to 10%, a moderate oral numbness, 21.1 to 31%, and also minor percentages of impairment of eating, drinking, smiling, and oral swelling. So there is some morbidity. However, this morbidity was related to the time from surgery and the length of buccal mucosa. These two had an effect on oral morbidity and complications. What is the long-term outcome? And I want first really to focus on functional data. And we were one of the first, already in the year 2002, to use patient-related outcome measures to get an idea. And I just want to focus on the buccal mucosa and on the end-to-end anastomosis. And at that time, we had a collective of 238 patients with a follow-up of 32 months. As you can see, in a buccal mucosa group, erectile dysfunction and deviation was less, and there was a high number of patients that had been satisfied, and maybe that the lower number of satisfaction in the end-to-end anastomosis group was related to this complication. So we did an update of this group 10 years later, and the patient were recontacted and also asked to fill out the previous used and self-administered standard non-validated questionnaire. So we had 51.4% available. And again, when we compare the buccal mucosa with the end-to-end anastomosis, what we could see is in the group of buccal mucosa, there was quite a high incidence of post-void dribbling, whereas we could confirm that those patients with an end-to-end anastomosis have a high incidence of erectile dysfunction and disturbances of sexual life. This is another publication from my institution where we had a look on those patients who were dissatisfied with the procedure. And these were altogether 16%. So when we look what was the main reason why they have been dissatisfied, it was in 28% recurrence, then in 20% oral morbidity, in 11% incontinence, in 9.6% sexual dysfunction, followed by pain, discomfort, and then urgency and urinary dribbling. So Guido Barbagli found that in an end-to-end anastomosis, about 20% reported a decrease in semen emission. And also after buccal mucosa, he has seen that in about 30%, and according to our findings, quite a high number of post-void dribbling. And he postulated that might be the nerves going to the bulbus spongiosus muscle might be responsible for it, and therefore he developed this muscle and nerve spurring bulbar urethroplasty. Another publication on the urethroplasty and post-void dribbling and ejaculatory dysfunction, also a quite high number. It was a multi-institutional investigation. You see ejaculatory dysfunction in up to 67% and post-void dribbling in 66%. However, this group has not found a difference between penile and bulbar urethroplasty, and ejaculatory dysfunction was for buccal mucosa and end-to-end anastomosis at least the same, whereas post-void dribbling was more often seen in a buccal mucosa urethroplasty. So this speaks a little bit against the theory of Guido Barbagli that these nerves are responsible. Again, another study, this was on the quality of life, and you see that the improvement of quality of life after urethroplasty was high. Satisfaction with surgery also, but again, post-micturition dribbling was frequently reported, but not considered bothering. And there was a mild erectile dysfunction observed with reduced rigidity, ejaculate volume and painful erection, penile shortening, curvature, and hypoesthesia of glands and scrotum. However, 90% mentioned they had no strong deterioration of their sexual function. I think Ye already mentioned this study, which was a randomized prospective study comparing end-to-end anastomosis with the buccal mucosa graft. And there was a clear difference concerning the tumescence of the glands or development of flappy glands and the penile shaft shortening. So the end-to-end anastomosis patients did worse. And this was also confirmed by the WESPA trial, where at least an interim analysis showed that the 3 months follow-up, the IIEF was different in the two groups with favor of the buccal mucosa graft. So what is the risk for incontinence? And this was also something Jay already touched with respect to irradiation. So it is postulated that prior irradiation and also prior surgery has an impact. And of course, the stricture localization. I put surgery after BPH in brackets and will show you some data on that. So this study investigated the quality of life in patients with urethral stenosis after radiation treatment for prostate cancer. And you may see that a high number, 2/3, had a urinary dysfunction, and 66.7% frequent and total incontinence, and over 80% an erectile dysfunction. This was a multi-institutional investigation, and again, post-prostatectomy and post-irradiation anastomotic stenosis. There was no de novo incontinence. However, already 1/3 of the patient had preoperatively, were only continent preoperatively. So the radiation-induced, the incidence for radiation-induced urethral stenosis and followed by at least incontinence has shown that in 1 of 5 patients, a new stress urinary incontinence will develop after irradiation in patients with stricture disease. On the other hand, after if a buccal mucosa urethroplasty is performed after treatment for BPH, only 1 de novo incontinence was described. Let's switch to the outcome of the urethroplasty, and this is also the old study of my institution out of the year 2002. And you see the overall success rate was 71% with quite a long follow-up. And here you have the different types of urethroplasty, and there was almost no difference. This is a more recent analysis we just did. These were urethroplasties performed between 2010 and 2013. However, in this analysis, also penile strictures were included. And as Jay already mentioned, also the etiology really plays a role. So, but we can say that in a long run, the success rate goes down. So these are honest data. We can expect for the whole collective a survival rate at 5 years of only 66% and at 10 years of 59%. So we need a little bit more data to make a subgroup analysis, because I believe that the bulbar urethroplasties are better than the penile ones. So in conclusion, surgery-related complications, we have bleeding, we have complications related to the subpubic catheter, and we have rare cases of compartment syndrome. Postoperative complication rate is low, 8.6%. Major complications are urinary tract infection, wound infections, deep venous thrombosis, pulmonary embolism, hematoma, incision pain, scrotal neuropraxia pain, and oralgia. At the harvesting site of buccal mucosa, we can expect bleeding, pain, swelling, and numbness. Concerning the intermediate and long-term complications, there is post-voiding tripling. This is frequent, and the patient should be informed, but usually not bothering. There might be urgency, and in a subgroup of patients, those who had previous surgery or let's say strictures in the area of the sphincters and irradiation, there is a higher risk of de novo incontinence. Concerning the erectile function, patients may expect reduced rigidity, curvature, penile shortening, floppy glands, and hypoesthesia, and also reduced ejaculate volume and painful erections. This is more often in the case after an end-to-end anastomosis compared to buccal mucosa. Concerning the success and recurrence rate, we have to expect a stricture recurrence rate of about 30% after 15 years, and it might be even higher for some of the subgroups. We have data on irradiated patients. They start out with a 71% success rate, and this goes down already after 2 years of lower than 50%. So thank you for your attention.